If you're a dentist who's often wondered why some poorly done root canals last for so many years, whereas some very well done root canals don't, then this video is for you. If you're new to the channel, my name's Siju Jacob. I've been a private practitioner in Bangalore and Dubai for the past 25 years. I've been using a surgical microscope in my private practice for the past 20 years. And I've been training dentists how to use the surgical microscope in everyday clinical practice for more than a decade. 2 weeks ago, I uploaded a video on this YouTube channel questioning the conventionally held norm that we have to do a straight line axis for everyday clinical endodontics. If you haven't watched it yet, you can watch it here on my channel. It's called Why Orifice Directed Axis Beats Straight Line Axis. This week, we are going to question some conventionally held norms of the entire disease model itself. If you are like me and you've observed some of the cases that come into our clinic, we often see endodontic cases that have broken all conventional norms of what a good endodontic procedure should be. Cases where there's absolutely no cleaning, shaping or obturation, but still have survived in somebody's mouth for more than 40 plus years without any signs of infection. Whereas you see some cases where the root canals appear to be perfectly done, but come back with a lesion after 6 or 7 years. If you're like me, you probably wondered why this happens. Well, in this video, we try and dissect our basic endodontic disease model and kind of put a question out there that maybe we should not accept things as they are and question the existing disease model occasionally so that we can continue our search or our quest as to how to perform clinical endodontics in everyday clinical practice so that the patient benefits from what we do. Before we get into it, I'd like to talk about two terminologies that I think is very important for any clinician to understand: cognitive dissonance and confirmation bias. Before we get into the endodontic part, let's try and understand what do we mean by these two terminologies, cognitive dissonance and confirmation bias. Cognitive dissonance is a feeling of discomfort that results from holding two conflicting beliefs. Now, if someone believes two different things, or if someone's beliefs are not confluent with their actions, then you develop what we call cognitive dissonance. Let's take a non-dental example to understand what cognitive dissonance is. Let's take the example of, say, a pulmonologist who preaches and lectures everyone on why smoking is injurious to health, on how smoking can harm the lung, but he himself smokes 25-30 cigarettes a day. Now, this is a classic cognitive dissonance where you are preaching something, you are preaching to everyone, which means your belief is that cigarette smoking is harmful to health, but at the same time, your actions don't match your beliefs, which means you are smoking 25-30 cigarettes a day. Now, in order to get rid of this dissonance, you have to do two things, or this pulmonologist has to do two things. One, he needs to stop preaching to everyone that cigarette smoking is harmful, or B, he needs to stop smoking. So one of the two things needs to be done in order to get rid of dissonance. So this is an example of cognitive dissonance. In dentistry, you could take the example of a teacher who teaches in the morning, lectures to students about how important the rubber dam is and why you should never place a composite restoration without placing a rubber dam. And then the same teacher goes in the evening to his clinic and then starts placing composite restorations without any rubber dam in his clinic. So again, an example of cognitive dissonance where what you are preaching doesn't match with your actions. So in order to get rid of the dissonance, this teacher has to do one of the two things. A, either stop lecturing on the importance of the rubber dam, or B, start using rubber dam in your practice. So one of the two things needs to be done to get rid of dissonance. So this is cognitive dissonance. Now let's look at the second terminology, which is confirmation bias. What is confirmation bias? Confirmation bias is a tendency to seek out and prefer information that supports our pre-existing beliefs. As a result, we tend to ignore any information that contradicts those beliefs. Now, again, to help us understand this terminology, confirmation bias, let's look at something non-dental. Let's look at Donald Trump, who is the president of the United States. And as you know, he's a very polarizing figure. In the US, you have two groups of people. The first group is people who absolutely admire him. They think that he's an amazing guy and an amazing president. And then on the other extreme, you have a group of people who absolutely don't like him. So you have two different groups, and both of these people have biases, and then they will look at evidence to support that bias. Now, the first group, who absolutely adore him, will look for evidence to support that bias that he's an amazing guy. So they will accumulate, or they will receive all the evidence that shows he's an amazing person. Whereas even if they tend to receive evidence that he isn't good, they will absolutely reject it. So this is known as confirmation bias. If you are on the other side of the camp, which means you're someone who doesn't like Donald Trump, then you will do the opposite. You will look at all the evidence to support your bias that this guy is not a great guy. And even if you receive some evidence showing that he is a good guy or he has some good qualities, you will reject it because it doesn't support your bias. So this is known as confirmation bias. Now, all of us are susceptible to these sort of biases. Cognitive dissonance and confirmation bias is a quality that virtually all of us are susceptible to, and endodontics is no exception. So what is cognitive dissonance in endodontics? This is a paper published in 2003 where Selzer and Bender pointed out that we as clinicians are susceptible to cognitive dissonance in endodontics. So what is cognitive dissonance that we see? Now, our whole specialty or the practice of endodontics is based on the endodontic triad of cleaning, shaping, and obturation. We believe that, or we've been taught ever since dental school, that if you do proper cleaning, shaping, and obturation, you will get success. And this is what we see in clinical practice. This is an illustration courtesy Cliff Ruddle. So where you have a tooth here and you have a pulpal space which is infected, you have infection in the bone, also known as apical periodontitis. And the logic is that this is because of bacteria, so all you need to do is clean, shape, and obturate and seal these portals of exit. Then apical periodontitis heals and you get healing. Now, this is the basic disease model of endodontics, and this is what we see. And we look for evidence to support this belief, and we get it very frequently in clinical practice. So you have a tooth here. This is a mandibular premolar, infected, lesion, clean shape, obturate, sealed all the portals of exit, and a year later you get healing. So this is our confirmation bias. The bias is that bacteria, clean shape, obturate, and you get healing, and this is the evidence for that. Now, the basic disease model is based on this paper by Kakahashi in 1965 and then supported by many other researchers over the years. You name the researchers, Sundquist, Nair, Jogren, and so many other big names, and their findings are true. Apical periodontitis is caused by microorganisms. So all the efforts that we've done in endodontics is to eliminate these microorganisms, and that's where the problem is. There's nothing wrong with the studies, but the problem is in how we interpret those studies and how we change that to influence our endodontic treatment model. And this is where the problem is. People have kind of dumbed it down to a simple formula, and that's where we have problems in when we are faced with evidence that doesn't support this particular disease model. And this is something that we need to be aware of as clinicians. This is the formula we always believed in. Shaping plus cleaning plus obturation equals success. In simple terms, it's A plus B plus C is equals success. So you just do these three things and you will get success every single time, which is what we are supposed to believe. And it works when you see cases like this. A plus B plus C is equals success. You have a case here as a pre-op where you could argue that somebody hasn't clean shaped and filled this properly. So all you need to do is clean shape, fill it properly, and a year later you get healing. So it supports this theory. Another case, you could argue that it's not clean shaped and filled well. So you retreat this case, clean shape and fill it well, and a year later you get healing. So amazing evidence for what we believe in. But what do you do when you get cases like these? 40-year-old root canals, absolutely no infection. None of these principles have been followed. No cleaning, no shaping, no obturation. But still, you don't have apical periodontitis and no infection. How do you explain these sort of cases? The answer is we don't. The current disease model that we have cannot explain cases like this. There are only hypotheses. We don't have any concrete evidence or explanation for these sort of cases. And that's the problem. And we know that when you have a case like this, exposed, no coronal seal, there is going to be plenty of bacteria here, right? But despite having a canal filled with bacteria, there is no evidence of apical periodontitis. And this is where we have problems. We don't know what to do with this when you get evidence like this that doesn't support our existing disease model. So in mathematical terminologies, when you get a case like this, you have A plus B plus C is equals failure, which means somebody has clean shaped and obturated a tooth all the way to the apex, and then there's still failure there. And why does that happen? We don't have a disease model for that. If I were to represent this particular tooth in a mathematical formula, it would be minus A plus minus B plus minus C is equals success. So there is no cleaning, no shaping, no obturation, and all of them are minuses, and you still have success. The patient's had this tooth for 40 years. So we can't explain this. A case like this, I treated it in 2006 and 2007, almost 15 months later, when you look at a recall, you see the distal root has healed. So you have A plus B plus C equals success in one root, And on the other root, the mesial root, which didn't have a lesion, has now started getting a lesion. So you have A plus B plus C is equals failure in the other root. So you have problems like this which cannot be explained with our existing disease model. And why it cannot be explained is because there is a problem with interpretation of data. Now, if you look at Kakahashi's paper in 1965 and all the other papers backed by numerous researchers after that, there is no doubt that apical periodontitis is caused by microorganisms. So if you have a lesion here, it's clear that there is bacteria here. And for some reason, if you do cleaning, scraping, and obturation, then yes, you do get healing, right? But what hasn't been interpreted is this question: does presence of microorganisms always cause apical periodontitis? The answer is no, because there is microorganisms here, there's plenty of microorganisms here, but there is no apical periodontitis. So we don't really know why some bacteria cause apical periodontitis, whereas in some cases, the bacteria remain there and there is no apical periodontitis. So there is some problem with this kind of disease model where we have to admit that our existing disease model is not complete. And often we see it in the same patient in multiple teeth. Now, this is a radiograph from the same patient, right? So you have a case where there is bacteria in this root, there is bacteria in these roots as well. So whereas in one tooth, there is apical periodontitis, and in the other root, there is no apical periodontitis. So how do you explain this? The truth is we can't. So this is the dilemma that we face in everyday clinical practice. So why are we talking about things like cognitive dissonance and confirmation bias and the fact that our disease model is flawed? It is to understand these three things. First of all, understand that our endodontic disease model is not perfect nor fully understood. We have some understanding, but it's not 100%. As a result, we always have to be skeptical about people who are extremely sure about everything in endodontics. This includes clinicians, academicians, whoever gets on a stage and starts talking in very definitive terms. All you need to do is enlarge 4004 and put biceramic sealers and everything will be fine. This is not true. Sometimes it works and everything goes well. And when you have evidence that everything goes well, it's great. But it isn't always the case, as we see with the available evidence. And the third thing is we need to be comfortable with what we call uncertainty in endodontics. For years together, clinicians, academicians, the so-called opinion leaders, all are very, very certain when they talk on stage or address an audience. This has to change because we know that the more you grow in this profession and the more you are open to new evidence coming in, we know that our existing disease model cannot answer all the things that you see in clinical practice. So one needs to be a little humble and not be arrogant or confident about our knowledge. We need to be comfortable with the fact or admitting the fact that we don't know everything in endodontics. We know some things, but we don't know everything. So that's the point of this presentation. If you enjoyed that video, then maybe you'd enjoy my weekly newsletter where I send one email every week with useful endodontic information. I've put the link in the description below to subscribe. And don't forget to check out some of my other videos on this channel. And of course, click on that subscribe button so that you get notified every time I upload a new video. I'll see you next week with another video. Thanks for watching.